Good afternoon, everybody. Welcome to UC Davis Health here in Sacramento, California. My name is Gagan Singh. I'm one of the structural heart cardiologists here at UC Davis. I'm joined by a very fantastic supporting cast here, along with Dr. Aman, who's going to be providing imaging services.
So this is a 78-year-old male. He has a history of coronary disease, had a prior CABG many years ago, as well as diabetes, had a prior stroke, and he's relatively frail. The problem with him, he's been admitted to the hospital, 2 or 3 times now in the past few months with acute decompensated heart failure, has sort of multiple issues, mildly reduced LV and RV systolic function, kind of mild to moderate MR, low gradient AS, which we had worked up with a valve study that really showed that wasn't really the problem, and then we're kind of left with severe TR as probably the most addressable sort of cause for his heart failure admissions. And so he was admitted yesterday. We brought him in, did a right heart cath. His filling pressures were mildly elevated, and so we kind of diuresed him overnight, used a little bit of milrinone for RV support to augment diuresis, and we brought him here. Now he's on the table, maybe Dr. Aman will go through some of the echo images.
Great. Yeah, let's transition over to Dr. Aman. And Edris, say hi to Hong Kong Structural Heart and tell us what you got.
Yeah, so here I'm showing you guys the transgastric view. It's not optimal. He has a large liver, which increases the distance from the TE probe to his actual tricuspid valve. Here's the transgastric view in 2D. I narrowed my sector width here. You can see the septal leaflet, the anterior leaflet, and the posterior leaflet. There might be a small posterior or secondary posterior leaflet here right at the septal posterior commissure. Really, you can see, though, it's mostly a trileaflet valve. When we actually put color Doppler on here, we can see the TR really originates centrally, maybe even septal posteriorly. So it's not a case where it's completely septal posterior, which would not be as advantageous to edge-to-edge repair. There is some central TR here. And if I go live here for you guys, you can see here the issue. So anatomically, what's happening is the right atrium is quite dilated. The right and left atrium are quite dilated. I believe the left atrium quantified to 93 milliliters per meter squared, which is very, very severe in terms of dilatation. And the right atrium is also severely dilated. There isn't very good deep esophageal imaging, so we're going to have to rely on the mid-esophageal imaging. So I'm going to increase my omniplane here to around 70 degrees, which based on 3D navigation, which we'll talk about later, is a very good bicom view. When I kind of put my MPR here, I'll get a 3D zoomed volume here, and I'll get a smaller volume to increase my frame rates. So here I am live here with the 3D. So I'll kind of orient myself. In our lab, what we like to do is put the aortic valve at 5 o'clock. So here what you're seeing is the septal leaflet, large anterior leaflet, which is common, and you can see that posterior leaflet right there. So I'm going to rotate this a little bit here. And if we put color here, you can kind of see the TR is mostly coming from right down the middle. So this is central TR, atrial dilatation, long-standing AFib patient.
So just to kind of recap here, what we're seeing is a patient with a little bit more tricuspid regurgitation than mitral regurgitation. The mechanism appears to be atrial functional kind of tricuspid regurgitation. We are his TR, quite honestly, doesn't look as bad as it was when he's awake, up and about, walking around. But he's had recurrent heart failure admissions with elevated BNP. So I do think that despite it being a little bit better now under anesthesia, this is probably going to.
No, I completely agree with you. When I'm looking at this anatomy, the real issue here is that his right atrium is so large that essentially it has dilated his annulus, and that's what's causing the TR. Hence, you get central TR here. So I agree with you, Gagan. If we just go and put, let's say, a septal posterior clip, we'll get shadowing downstream towards the aorta, so we're mitigated to drop. We will be unable to essentially put clips in the SA. So starting at a mid-SA XTW would be a great idea. And then if the TR is still there, or we feel like we need to maybe put another clip on for stabilization, we can tackle central SA, or we can actually go to the septal posterior, depending on the residual TR.
Got it. Have ipsilateral axis. I have the top sheath, which is currently an 8 French sheath. It's been we made a skin nick out to about 24, to tolerate a 24 French sheath, which is going to be the TriClip guide. After dilatation, I have a single ProGlide here. And then right below it in a stacked configuration, we have a 10 French sheath. So again, they're about 1 centimeter apart, but the patient's veins can definitely tolerate that. And I'll show you guys later what this allows us to do is to have a little bit of a better ergonomic approach to the case, because the ice catheter will sit right here, as you can see on the screen, and then the stabilizer will sit right here, and we're not reaching through the device. So I'll kind of take you guys through that. So what's nice about the Philips 3D ice catheter is that Dr. Aman can just toggle the ice catheter on for me, and I'm controlling the ice catheter, but Dr. Aman is controlling the console. So Edris, right now I'm at 0 degrees, and we're always going to manipulate in 0 degrees. I have a little bit of clock, a little bit of counter. How do you like that for kind of me centralizing the valve for you there?
Yeah, it looks beautiful. The aorta right now is about 3 o'clock or so. So this is a nice home view at 0 degrees.
Okay, great. So you want to go ahead and get some color on and make some initial measurements, and then I will go ahead and try to, if you want, I can clock here. This is me clockwise rotating. This is me counterclockwise rotating. There's all that TR that we were looking for.
Yeah.
So definitely a significant amount of TR here on ice. So now you're at -45. So let me optimize this. I'm going to go ahead and do a little AP flex, clocker, counter. And how does that look there for you?
I think that's really good. The aorta now is at 3 o'clock. So this is similar to the RV inflow view we had previously. If I put color here, you can see the TR is mostly central and a little bit septal posterior, just like we thought in the TE. So I can get an MPR off this if you like, Gagan. So now we're on multi-view, and this is the new VM11 system. Our planes are locked. I'll ensure the blue plane is cutting the leaflet tips, just like we did on the TE. So on the top 2 panels, blue plane is cutting the leaflet tips. This then becomes a transgastric. I always make sure my bottom 2 are about the same here. So now so you can kind of see things there. Just to confirm the aorta. And sometimes when you're looking at 3D ice, you can actually look at the 3D rendering. You see that septal leaflet there, anterior leaflet here, posterior. If you want to confirm aorta location, you just right-click up here where you know the aorta is. You can see the crosshairs and the 3D ice jump right there. So aorta is at 5 o'clock, exactly where we'd like it to be. I'll right-click back so the blue plane is cutting the leaflet tips again. And now it's really about ensuring the red plane is the alignment we like. So if you look at the 3D rendering, really it's a question of, is Gagan happy with the 3D rendering and the way the red planes align? So Gagan, what are your thoughts on
that? Looks really good.
And so that means this is your grasp right here. This will be your septal. This will be your anterior leaflet.
Yeah. And that's all with MPR, just straightforward MPR, not utilizing 3D navigation. But you can see how much better we can see the septal leaflet, how much better we can see the anterior leaflet. And for TEER, what's most important is that you can see the leaflets not just during systole, but during diastole too. One of the common limitations of transesophageal echo is that we can always see the leaflets as they close, but as they open, then you can't see them. And so when you're trying to do leaflet insertion assessment, that's where the challenge comes in. So I think this is pretty good here, Edris, and I think let's highlight for the group just the 3D kind of pre-procedure 3D navigation, what we think is going to be the best way. I mean, it might just be this, right? It might just be +45 based on what we're seeing here.
Yeah, it looks like if we go to +45 alone, or if you go to -45, we can just do MPR if you like. So I think any of these techniques will work well, Gagan.
Yeah, so let's do this. Let's go back to 0. And just for illustration purposes, so people understand 3D navigation versus what we just did. What we just did was classic MPR. Now we're going to do 3D navigation. And so basically I'm going to pull the ice catheter back just to reset. I'm going to bring the ice catheter in. So now we're going to go ahead and optimize my 0 degree view. That looks about the best I can do here. Edris, why don't you switch to -45?
We're at -45 now.
Good. And then why don't you go ahead and build me a 3D nav map?
Okay, one moment. It's going to come up here. You'll see your 3D nav map in a moment. I'm rotating down here.
Perfect. So what I see, Edris, is that my crosshairs in the 3D map that you're giving me are over the anterior leaflet, and I'm a little bit caval, so I'm closer to the IVC. So now what I'm going to do, Dr. Aman, is I'm actually going to go ahead and clockwise rotate my ice catheter just a little bit, and I'm going to push my ice catheter in. Now I think what are your thoughts? Do you think the image needs to rotate a little counterclockwise on the screen, or we're pretty close? I think we're pretty close.
You're pretty close. I agree with you on that.
So basically what this tells me is that with a little bit of manipulation that I did, and without Edris having to adjust any of the planes, automatically what we're seeing is that our red plane now is situated over what our grasp is going to be. So Edris, do you want to take us straight to a X-plane view now?
Mm-hmm. So what I can do here is you can see here the 45 degrees here in this middle portion, Gagan, like you talked about. That correlates with this red plane here.
Excellent.
Right? So now I'll go straight to a 45 degree if you like, Gagan.
Yep.
Okay. going straight to 45 degrees. So that's your grasp view.
And that's your grasp right there. And so look how beautifully you can see the septal leaflet and the anterior leaflet there. And so this tells us, again, with this little pre-procedure case planning that we don't always do, but at least here for the purposes of illustration and education, that this allows you to very quickly see the septal and anterior leaflet, and we know this is what we're going after. And I think what we're going to do, Edris, is I think given the central nature of the TR, we'll start off with an XTW and we'll go AS mid to central and see what the TR looks like. And if it looks like we've abolished most of that central TR, then I think we're going to stop at one clip. And then if we need to put one in SP, then we do that. How does that sound to you?
Sounds perfect.
I have a half turn negative on right now, so that definitely extends things. You see how I'm kind of hugging the septum a little bit? If I counterclockwise rotate, I want to see if that moves me away from the septum. See if you can find me there again, Edris.
Move a little more posterior
yeah,
to find you.
Didn't really, so I just did a little clock. So really it turns out I can either do more negative, and you see how that pulled me away from the septum. So I think this is probably a good place to start here, huh?
Yeah, I agree.
Okay, great. So now what we like to do is rather than push the system out, we actually will go ahead and kind of unsheath the device. So what I'm doing here is Edris is showing me the tip of the clip. I'm going to advance the clip out. Now I'm going to pull the stabilizer back 1 millimeter. Advance the clip out 1 millimeter and pull the stabilizer back. Advance the clip out a little bit, pull the stabilizer back. What that does is that he doesn't really have to go hunting for me, right, Edris? I mean,
yeah.
You pretty much, we're there on the screen the whole time. I'm making a little bit of contact with the tissue in the SVC, but it's all moving slowly. And now we've basically reached straddle. So now we're ready to flex down, Edris. I'm actually going to pull the whole system back just a little bit. I'm going to start flexing down. And sometimes what happens is we're seeing this here. As I flex down, it wants to make contact with the septum even more. So we can counterclockwise rotate a little bit, see if that moves me away. And as I flex down, you see how it's still making contact with the septum. So there's a real easy fix for this. We can actually put a little bit of L knob on right now. So I've put on a half turn L knob, Edris.
Mm-hmm.
And that actually pulled me away from the septum.
Yeah, and as you're doing that, I'm dropping the omniplane.
Yeah.
To kind of get you looking better.
And so it looks like I'm very septal right now, and I'll just counterclockwise rotate. And that should have moved me off of the septum.
It did.
Okay, good. So I'm going to keep flexing down. So it looks like we've flexed down quite a bit now. I'm going to I have a lot of negative on, so I'm going to start taking my negative off, and that'll bring me down to the valve.
I'm going to bring clip down a little bit.
No, it's okay. I would leave it right where it is. So it looks like I'm still pointed fairly posterior caval, Edris. I'm going to take a little flex off, move the system in. All right, so it looks like we are down to the valve now. What do you think about our trajectory and our inflow and NPR view? I have right now maybe a half turn negative on, a half turn L on. Do you think you want to build an NPR here to see our trajectory?
Yeah, I think we can. We see leaflets well here in this view, so I think it's a great view to build NPR off of.
Okay. And I can get a little closer to the valve if you'd like, or you're happy with where it is?
Whatever works for you.
Yeah, okay. I'm all about pleasing the imager.
They ordered at 5 o'clock in both views. The green plane will be parallel now to your septum. So that's your location right now, Gagan, a little bit posterior.
But our location is posterior or towards the IVC caval. But I would say our approach, our trajectory looks very good here. So I'm actually going to push the stabilizer in. Mm-hmm. We're going to go ahead and push the stabilizer in, move more aortic. And how does that look right there?
That looks like a great location. You're probably more mid-SA here. You can kind of see here in the transgastric-ish view. You're right there.
Perfect. So I think at this point, what Akshay is going to do, he's going to open up the clip arms. And we're not going to open them up all the way.
Okay, opening clip arms.
Mm-hmm. Good. I think that's a good place to start here. And real quick, since we're here, we got a beautiful NPR. We're going to do a tactile marker check here.
Okay, tactile's coming down.
Tactile is anterior. Non-tactile is septal. Okay. So that looks really good here, Edris. And now let's start working on our alignment based on NPR. And do you want to walk everybody who's viewing this how we do it, how you've kind of taught us to do it here, looking at NPR.
Yeah, so the top two planes we talked about with our NPR constructions, the blue plane is cutting the leaflet tips, right? So the blue plane represents this panel. So what we're going to do is we're going to grab the blue plane, we're going to move it up to our clip arms here. So you just merely left click here. After you left click, you move the blue plane up to the clip arms. And now you can kind of see here in the blue plane, that's actually your clip alignment, right? And if you're interested, you'd say like, okay, well, that's what my clip alignment is. Let me go back to the leaflets very quickly. And do I feel like that's a good alignment? So really, Gagan, it's up to you in that way. So what do you feel about this clip alignment? I think it looks really good.
Okay, I think if you think it looks good, yeah, we could keep it here. The good news is that this gets us close enough, and then obviously once we're underneath the valve, you could grab here, or what we like to do is go to transgastric, and we'll show you that technique, because really, you know, as Dr. Aman likes to call it, that is our true north, and it gives us the best amount of visualization. So how about we do that, huh, Edris?
That sounds great.
Okay, good. So what do you think about this location? Do you want to put a little color jet here to see if we need to pull back anymore? So it looks like we're right close. I can try to scooch this thing a little bit more central. Because we're not going to grab the gap itself, right? But we're just going to grab kind of AS mid to central. How does that look right there?
Yeah, that's more central SA there. That's where you're sitting. And I think that's a great location. You're at the aortic edge of the TR jet.
Okay. In this, Edris, that looks good to you?
Yeah.
Okay.
I think this is absolutely fantastic.
Oh, yeah. Arms are closed. So arms are closed there.
Yeah.
So I'm going to go ahead and start advancing in. That's about 1 millimeter advance there. My alignment hasn't shifted. My position in the inflow view looks pretty good, Edris. Advancing in a little bit more. Just rotated just a little bit anterior. Kind of advancing in a little bit more. Advancing in. Okay, so we should be below now. My parallax is pretty much maintained on top there. So now Akshay is going to go ahead and start opening up the arms.
Opening up arms.
Good.
Stop there.
Okay, and so we're going to stop right here, Edris. And then I'm going to push in a little bit and kind of fix my parallax just a little bit. Okay, so I think we're ready for transgastric, I think.
Okay,
what do you think?
Yeah, I think absolutely. Just going to try to decrease my sector width and depth as much as I can to increase our frame rates.
Okay.
And increase our spatial resolution. And now really, for me, it's about really finding these leaflet tips the best and getting the best transgastric view so you can see yourself the best.
Okay. So I pushed in just a little bit. I'm going to take a little bit of F off. And now I'm going to I just pulled back. I'm going to push in again.
Yeah, I think that's it right there, Gagan. I'm not going to move here now, Gagan.
Okay. So I see anterior is on.
Anterior is definitely on.
Yeah. And do you think I have to clock this a little bit more? Or do you like the alignment right now?
I think you're okay with your alignment, actually.
Okay.
Let me make a little adjustment if that's okay.
Sure. What I just can't see is septal.
Septal, and I agree with you. I can't see septal either. And sometimes that's the case depending on how you've come in. You get shadowing over the septal leaflet.
Yeah. Okay.
Oh, we've lost everything there.
So one thing we could certainly do is obviously once you're ready for it, you can switch to an NPR, or I can switch to ICE here. This is a great example of where ICE would help us.
And I think that in this case, if I switch to NPR transgastric, we'll see anterior leaflet, which I believe you have. But I think septal, because we're not seeing it very well here in our 2D, we're not going to see it well in NPR. I'd vote for 3D ICE, Gagan.
Okay. So do you want to switch to 3D ICE?
Yeah. Okay, 3D ICE is live now.
Okay. So I'm kind of looking in the wrong direction. I'm going to go ahead and rotate around to start looking down at the imaging there. And I'm going to go ahead and, let's see here, optimize my 0 degree view. Okay, Edris, that's my 0. Let me see if I can. Okay, so that's 0 there. So let's go ahead and if you want to build my 3D nav map, I'll try to get this over to.
This is minus 45.
Okay, actually it looks like we might just be there, huh? And we already determined our plus 45 is going to be our grasping. So if you want to just X-plane first off of negative 45, Edris, I think that might be, or I guess not. Look at that.
Tell
everybody at home what you just did.
Yeah, so I'll kind of go over it. So what I did was he talked about explaining off of -45 to get 45, which is absolutely a great way to get a grasp view. Another technique is to go straight to 45. And there's a feature called tilt elevation. And what I'm really doing at 45 degrees is I'm fanning either away from the aorta or towards the aorta. And what I did was I knew where I was, that we were maybe a little bit more aortic relative to the clip. And so I just fanned here. You can see here this right image says -9. So I added 9 degrees of tilt away from our actual location. And when I did, I can see the arms very well. I can see the leaflets perfectly. At this point, I can decrease my sector width because I'm really interested in that, my depth. Zoom up. Now Gagan gets a great grasp view to drop his grippers,
Yeah.
etc.
And it looks like I'm in the center of the valve right now, which is good. And Edris, I guess the one question I have is my alignment right now, because on floor it looks like I have shifted a little bit. So I don't know if you want to switch to TE to confirm my alignment, or
Sure.
if you want to just build an NPR here and see what we get from here.
Why don't we build an NPR? Just see what it looks like. Okay, let's just see what it looks like here. And you can see here with our new with the new VM11 software from Philips, our frame rates here are 13 hertz, which is pretty good. You can see the leaflets falling in quite well on NPR, which is what we predicted, Gagan. We started the case that NPR would be a good grasp view. Here I'm rotating.
Predictable procedure.
So I'm going to right click here. As you can see, aorta, Gagan, is right here, 5 o'clock, just like we like. I'm going to right click back to it. So there you can see the red plane here is cutting the leaflet arms very, very well. I'm going to drop the gain a little bit. I'm going to increase the gain.
Okay.
If you look here, I think you actually have a good alignment. That's what I think based on 3D.
So I think the alignment looks okay. So we'll just stay here in NPR then, and grab.
Yeah, if you want, I'll make the grasp view large. So I just changed the layout of things, but you can see the leaflets now falling into the center of the clip. Here's now, and I'm going to rotate to your clip arms, and you'll see yourself right there.
Yeah, and I can, just so everybody can see it, I can push in a little bit. I can come a little bit more anterior. I can re-engage the leaflets, which I have right there. All right, Akshay, go for it. It's your shining moment. Once Dr. Aman shows it to you. Yeah.
There we go.
There you go.
Okay,
Good.
grippers down. Lock plies down, closing arms. Slowly closing here.
And I'm slowly advancing just a little bit. Yeah, and I would stop there.
Okay.
All right, Edris.
So what I'll do now is, so since we were on explain tilt elevation, the nice feature of this is I can actually just fan through. So I can slowly move my tilt elevation. There you can see the clip. You can see the leaflets. I'm going to slowly fan through, and I keep fanning, and this looks like it's all, this is on one side of the clip, and I'm going to move back to the clip slowly, and I'm moving degree by degree, so you can see right there that anterior leaflet falling in. So right there, that anterior leaflet fell in right there.
Beautiful.
Now focus more on the septal. And if you felt like this angle wasn't the right angle and you're the imager and you're in control of the machine, what you can really do here is you actually can just change the angle you want. So you can see right now at 55. So you can change the angle to what you feel like would be the right angle. But since we're using 3D navigation, things are quite precise. So we just really just stick with the 45. Yeah,
so of course, the most important voice in the room is our Abbott clinical support. So I'll look over at Teresa. What do you think, Teresa? All right, Teresa said that was the best grasp she's ever seen. I don't know why that's funny, but
I'm just going to put color on now, Gagan, and I'm going to rotate through.
Beautiful.
And this looks wonderful. You can kind of see everything really nicely here.
All right, so we're happy with leaflet insertion. We're not fully tight yet, but if you want to maybe go back to 0, and then we can tighten and do our final leaflet insertion, go to transgastric, go to mid-esophagus, and deploy this thing. So now let's see color here, because this is where we saw the most amount of color, right? And there's 0.
Yes.
So let's see color here now.
Oh, wow.
Somebody record that. He said, oh, wow. And so now what we're going to do is this. I'm going to try to centralize this thing first. There, I've centralized the valve, the arms there. So now just go ahead and give me a X-plane there. Okay.
60?
Yeah.
There's
or 45 even, yeah. Okay, good. So now put color on and we'll tighten.
Color's on.
Good, so go ahead and tighten.
Tightening here.
Yeah. Okay, we're max tight, Edris. That's good there.
I'm going to go back to 45 tilt elevation, Gagan, just to reassess really quickly.
Okay.
Tilt elevation is active at 45. I'm rotating slowly. Looks like everything has stayed the same. Yeah, it looks good. I'm going to put color on as well and rotate. So now I'm just rotating through at 45 degrees on either side of the clip and just looking.
Beautiful.
Yeah, I think at the end of this, you're going to have trace TR at most.
Very nice tissue bridge that we're starting to see here on Echo there.
Wow, even on 3D, you can see a tissue bridge. Here on the 2D, you can see the tissue bridge. Here's the septal leaflet falling in. See the anterior leaflet really falling into the clip here. My red plane is right over the clip arms here, so you can kind of see here. Here's the clip. This is your actual grasp view right here. This looks absolutely fantastic. If I want to assess this, you can grab this blue plane. You can move a little more cable while looking at the red plane. Come back. I mean, this looks great, Gagan. I think you absolutely have leaflets in there all the way in V. Put color on here as well.
Great.
And there's really no TR here on MPR any longer.
All right.
I'm going to put some color on here in the RV inflow. You can see there's just a trace TR just posterior to the clip.
Yeah.
Get your aspirin.
Beautiful. And it doesn't really go back very far.
I'll give you that.
No.
So I think that the location of this clip would be really nice. And then, so what we'll do is we'll close maybe on 3D ice to do a color compare. Yeah, beautiful. So, all right, so we'll finish off, kind of provide some closing comments here. So again, you know, we were able to show that this patient has on transesophageal echoes, on surface transthoracic echoes, TR that's closer to 4 plus. And since he's been in the hospital, we put him on a little milrinone, optimized him, but he's had recurrent heart failure admission. So I think this is the best thing that we can offer him. What we see on the left image and compared to the right image, obviously, is pre and post. So Edris, do you want to take us through what you see here?
Yeah, absolutely. So we're at 0 degrees. You can see here a central posterior jet. We know from our imaging that it was mostly due to annular dilatation due to severe right atrial enlargement. And here now we have our clip that was in the central, mid-central septal anterior position with very trace residual TR. And really what you'll note over time when you use 3D ICE is that if you're seeing this on 3D ICE, it'll be less on TE, and it's even less on transthoracic. So 3D ICE is typically the most sensitive when it comes to TR visualization.
All right, great. So there you can see one clip in the AS segment. And I like the way this looks. So final comments, if you can just show Dr. All right, so we'll close here from Sacramento. I want to thank the organizers for this Hong Kong Structural Heart Conference. We're excited to be there. Obviously, this case was recorded a few weeks prior to APCASH, but on behalf of Dr. Aman and myself, we want to thank you for this great, fantastic opportunity. We want to thank, obviously, Abbott and Phillips for supporting us for this case today. And also MedInbox for the live case recording, and which we'll splice together and we'll show it to you at the conference. So thank you again for the opportunity, and we'll see you in Hong Kong in a few weeks.